Hi, everyone. Welcome back. I'm Gabriel Allen Cummings,
And I'm Brad Davidson, and this is Breaking the Code,
a podcast series by the Havas Medical Anthropology team. We're here to take the BS out of behavioral science by illuminating the why behind the what of behaviors, rituals, and symbols that people take for granted.
We hope to arm you, our listeners, with the tools you need to make sense of behavioral science and to help you to apply it as your work as communication extraordinaires. So this is a special episode, right?
Yes, this is a special episode, Brad. We have been doing work with a team for a cancer pitch, and one of the insights that we've come up with for them, they wanted us to dive a little deeper on, and of course, we're happy to do it on Breaking the Code.
So it sounds like we're really talking about moments of diagnosis and then post-diagnosis, how people perceive themselves. So just to orient people to time and space who've not heard the podcast before, I'm a linguist, but I was trained as a field linguist. My studies were in hospitals. So I studied how doctors and patients talk. I studied in my postdoc, I studied how doctors told patients they were dying. So I followed a lot of patients who had bad diagnoses, and it was at the Stanford Lung Clinic. So a lot of them had lung cancer diagnoses. And I learned a lot about that moment of transition from, I don't want to say hope to hopelessness. They always tried to keep people from that sort of sensibility, but there's a real challenge in talking to people who've been given what's essentially to them what they perceive as a death sentence. And so it sort of has a way of sharpening things for people. It has a way of clarifying things for people. There's this famous acronym DABDA from Kubler-Ross, right? The denial, anger, bargaining, depression, acceptance. These sort of stages that we cycle through. The original idea was you hear a bad diagnosis, you deny it, it's not true, let's get another test, and then you're angry about it. How did this happen? And then you bargain, well, if I just treat it a little bit, but I don't want to do all of it. That you'd go through these stages. Depression would be, holy crap, I really do have this thing. And then acceptance is not, I love this thing. It's really, I can get on with my life. And there was this idea that there was a sort of forward progress through that. We now understand that those phases are real, but you can wake up on Tuesday and go through all of them, and then wake up on Wednesday and go through all of them again. So I think this DABDA thing, when it comes to lung cancer, one of the things that people have to deal with is their own guilt, right? That I smoked for many years, like many people in advertising. I smoked for many, many years. And I am aware that I have a much higher likelihood of getting one of these cancers than someone who didn't. And I'm aware that if I get that diagnosis, I'm going to have to look at myself in the mirror and go, unlike people who started smoking in the early years, I started smoking well after the Surgeon General told us what was going to happen, you know?
And to add to that, Brad, I mean, is it just the shame of looking yourself in the mirror and saying these past actions that I knew were bad are coming back to get me? One of the things that we were talking about and reading about was like how it kind of permeates into the rest of my life. Now my family has this burden that they're picking up on.
You know, I think so. Two things. One is I've worked in many respiratory categories. I've done a big ethnography of COPD patients. Their sense of guilt about what they did to themselves with COPD often prevents them from lobbying for themselves, especially if they continue to smoke. So they'll suffer through a hot August in Philadelphia, not leave their house, but also not make a special appointment to see their doctor. They'll say, well, I've got an appointment in September. Why hurry? That's not it's not a made up example. That's a guy I interviewed who hadn't left his house in Philadelphia for a month because it was too hot. And he was just like, what would be the point? And so I think there's a lack of efficacy for some of these patients. On the other hand, I've had doctors say to me, I don't blame people for this. It's the most addictive thing known to man. And they hooked people when they were like 13, 14. And that's exactly when I got hooked, right? It was $1 for a pack of cigarettes. You got 2 free books of matches with it. And off you were away and running. Nobody ever ID'd you at the corner store. You just started smoking Marlboro Reds. You know, that's what people did in 1983, 2 kind of time frame, right? You know, I think there's a sense that there's less empathy to go around, certainly when it comes to things like institutional funding. I don't have any insight into that, but I know that doctors themselves make a point of not trying to stigmatize patients.
Right. I was going to ask you about that. The idea that people are receiving additional stigma, you know, a lot of different terms on the internet are like, you know, play stupid games, win stupid prizes.
Right.
So how am I supposed to feel empathy for something that you caused, something that's effectively your fault?
Right. And I think for doctors, that's really got to do more with, are you actively harming yourself or is this in the past? Right. And again, I think this idea of self-stigmatization is pretty strong. I do go in for lung scans. I am deeply into the group that's supposed to be getting annual lung scans, and there's stuff they're looking at, and I feel stupid every time I see it. You get this sense of inevitability that, like, well, you did that. It can lead to nihilism, but it can also just lead to depression. So I think we have to be very careful about how we phrase this around the smoking-driven respiratory in particular. The one thing I would say, though, that is evidence that no matter what people are saying, that they don't have stigma, is counter sort of narrative to that, is when people will say, has lung cancer, never smoked. And they do seem to feel a need to call that out, that like this was not a self-inflicted injury, almost like if you remember Ryan White, you're too young, but he was the young man who got HIV from bad tainted blood transfusions. He became the face of AIDS back when we called it AIDS, right? Funding, because it was much easier to ask people to give money for a young, white, innocent, air quotes, child who got HIV than somebody who had been engaged in IV drug use or gay sex or any of those things that would get you HIV, we now call it, right? It was clear that like the quote blameless victim was more appealing. And I think that's true. That is true on some level in lung cancer, that if you feel a need to call out like this was a non-smoker, it is a little bit of a categorization by negation kind of thing, like leaving the rest of the group to go like, well, the average lung cancer patient is a smoker, and with all that comes. Does that matter? Not entirely. Some of it is if you are a smoker and you get lung cancer, you got to check for emphysema. You might have reduced respiratory function anyway. You might have other vascular issues. Smoking does lots of terrible things for you, not just.
Right. And one of the things I'm thinking about now, based on what you were saying, was this perception. We know that a cancer diagnosis right away, it changes who you are, how you see yourself. And we've kind of unpacked that through the notion of shame and how that's experienced. But zooming out further to late stage cancers, of lung cancer, we've talked about a lot, ovarian cancer as well. I want to talk more about the conversation around cancer.
It's changed tremendously.
Right.
Even in my lifetime. So my postdoc was somewhere called the Stanford Center for Biomedical, which was set up by a legal scholar and a medical professor at Stanford who really wanted to get into the ethics of various things. And at the time, it was genetics was brand new. We were still doing the Human Genome Project over there on the West Coast, and they were very concerned about things like economic credentialing based on your, BRCA or HER2 stat, whatever. I can't remember the conversations back then, but what was very interesting was several conversations I remember being party to, had nothing to do with what I was studying, that breast cancer had been overfunded and was oversaturated. Not that anybody thought that breast cancer didn't deserve to be funded, but in 2001, even then, they were saying in a race to close the funding gap, we were made aware a long time ago of a funding gap between male and female research on male and female bodies. And so for a number of reasons, you can check yourself, right? You can palpate your own breast. You can't really give yourself your own pelvic exam or examine any, your cervix for that sort of stuff. So it's a do it yourself in some ways, but also it was even that. So it's funny, even 24 years ago, people were saying like, there's just too much attention on this type of cancer. Not that it doesn't deserve it,
right,
but that there are other cancers that are just as lethal. And if they could have, they almost predicted the idea that the NFL would have a month of pink. And I think one of our colleagues said it best, like breasts are what men care about in female bodies. Ovaries don't really hit their consciousness. They can't see them, right? So there's still a sort of sexist focus on external secondary sexual characteristics, let's say.
Right. And I think it may also, yes, to your point about like ovarian cancer, cervical cancer, we even only on a few episodes ago to talk about the attention that needs to be paid there.
Right.
But also the idea that the idea that survivors who usually catch it early are the ones that we will celebrate, the ones that we will put on the pedestal. You'll see that more in early stage cancer, your breast cancers that are easier to catch than something like an ovarian cancer, something that's more deadly.
Yeah. And, there was a lot of conjecture back when I was having these conversations all the time. And I do know that there are certain things that we don't like talking about. So again, breasts can be, turned into a punchline much more easily than the internal reproductive organs. I think one of the things about like caught early versus late and survivorship was even then, and especially now, what is a survivor? Right?
Mhm.
When do you call somebody a survivor? So there have been a lot of really good articles written from all sorts of points of view. Women who are actively fighting cancer want to be considered cancer survivors. Women who are on adjuvant hormonal breast cancer therapy for 5 years post being declared cancer free, but still at cancer risk, they call themselves survivors. Famously, Angelina Jolie called herself a survivor because she had a double mastectomy, but it was prophylactic. She never had cancer.
Mhm.
She had a cancer marker. She was BRCA positive, I believe. And that really ignited a debate. Like, can you be a pre-survivor? You know, can you look at survivorship in this sort of black and white way? Do we reserve survivorship only for those handful of women who get declared completely cancer free at 5 years? What about all the people who are living through the struggle now?
Right.
Um,
And just to the
yeah,
survivor point, I'm really interested in that as far as like we were just talking about shame and what role does that play in
right,
self-identifying as a survivor? If I smoked for years and I got
right.
this cancer and then the cancer free, that's a great thing in and of itself. Now, when people say hero, survivor, going to the war metaphors you were just transitioning to, Brad, I think there may be an additional pressure, an idea that I don't want to be like, I don't want my entire identity to be cancer survivor.
Am I a hero just for being alive?
Mhm.
Right. Just like, that Trevor Noah book, Born a Crime. Am I a crime just for existing? Am
Right.
I a hero just for being alive? And I think a lot of people reject that. I think it's an attempt, a noble attempt and a worthy attempt. And it seems like a default attempt in some ways. Like we always come back to this to like, we want to make people fighting cancer feel seen and supported. And a sort of default stance is then we'll celebrate them,
Yeah.
right? Sort of like they were the LeBron James of cancer survivors. And that's very confusing for a lot of people with cancer who are going through a lot of other very practical stuff. I know for a fact that there have been at least 5 articles on why we need to get rid of the war metaphor. I mean, 5 peer-reviewed articles or articles in medical journals,
Hmm.
not linguistics journals, saying, I really want to get rid of the war metaphor. I don't want to be bombing things. I don't want to be fighting. I don't want to be doing all this stuff.
Yeah.
You and I have talked about this before. I think the framing of cancer as an invader to be expelled lends itself to this idea of aggressive, very, very hard sort of energy. But this idea that I don't want to be seen as a fighter, it's just another thing I'm putting up with.
Hmm.
And again, I'm not a woman, neither are you, but certainly interviewed enough people, certainly heard enough people talking. There are burdens people carry all the time. This is an additional burden. Now, this may be the additional burden. This may be the defining burden.
Right.
Certainly, people often refer to moments of diagnosis, and it's not just for cancer, but often for cancer as a 9/11 moment. Like there's a
Hmm.
before and there's an after, and nothing is the same after this diagnosis. Probably true
Yeah.
psychologically. It brings mortality very, very close.
Hmm.
But we've completely changed how we view cancer in my lifetime. Now,
Yeah.
not in my consciousness, but in my lifetime. So I was born in the very late 60s. I'm an old Gen Xer. And in my lifetime was the first time somebody really talked about having cancer on TV. It was Betty Ford, and she came out and said, breast cancer. And that was shocking. It was seen as, for a long time, it was seen as mark of the devil, right? It was a mark of, evil manifested in you. And so they literally would sort of look at you and go like, well, what did you do? And so we have to think that that is still sort of a little bit in the background. That's why people used to whisper cancer. That's why people get called things like cancers in the locker room and stuff. Like it's something to be excised. It's something to get rid of. But by the time, we had people running for president with cancer, Rudy
Hmm.
Giuliani and John McCain both had prostate cancer when they were running for cancer, and it was a non-issue. That would have been impossible to both publicly announce that you had cancer and then to actually to be allowed to even consider running for president. It was interesting that it was of all the issues around those two candidates, two of them had cancer and that was never brought up. I think it would have been seen as terrible. And that was, a very historically short turn from Betty Ford making huge waves. Was it Betty Ford or was it Patricia Nixon? I was so young. And it might have been Patty Nixon. I'm going to have to look that one up. So I apologize for the factual inaccuracy. Let's just say the wife of one of the president or vice president came out publicly on TV with cancer, and it was when I was 4. So I don't remember exactly who it was.
And let me just say one more thing to the war metaphor. Something that's bothered me even before I got in this position or had this role was this notion that when people pass away from cancer, it's as if they lost the battle. I'm someone who likes to design games in their free time.
Right.
And so when you think about winning or losing, that's something that you can kind of go back to the drawing board, something you can learn from. But there's also an additional pressure that's added to winning and losing that I feel like when we talk about cancer, when we talk about these late stage diseases, things that are, fatal, things where the control is not completely in the hands of the person who has it, puts an unnecessary pressure.
Yeah, you're going to die of something. I don't know how to say that, right? Like, so, and everybody who's listening to this, I'm not trying to bum you out, right? But like the game of life is played to lose. Mm-hmm. So it's really what you do in the middle. And that's what I learned, as a young dude doing this postdoc. I mean, I was in my late 20s, but I still felt younger than the people I was sort of talking with. It's an opportunity for perspective. It's an opportunity for reflection, for an evaluation of what you've been and done and where you've been. I think for a lot of people, there is this sense of like, I got to hurry up and get it all in. But for a lot of other people, it's more, again, I just need this thing not to be center stage.
Yeah.
Right. I'm not going to beat it. It's not going to beat me. It's likely to be this. That's a little clarifying for people knowing, the bullet with your name on it, to use another war metaphor. But this idea, like, I might not beat it, but I can make sure it doesn't take over my life, and it doesn't take over my family's life, and it doesn't define my legacy, and it doesn't spend the rest of my waking hours thinking about it. And that's one of the reasons, actually, that people continue on 3rd and 4th line cancer therapies. If they start to sort of get the sense that the juice isn't worth the squeeze, that I only have so much time left. My uncle passed away a few years ago. My favorite uncle, only 10 years older than me, much younger than my mother, who's more like an older brother. He very quickly decided that he was not going to go through the kind of really punishing chemotherapy regimen he was going to have to go through to have any chance of survival. And it was a very small chance. And I was very surprised because he seemed like the kind of guy who would have taken a 2% chance and run with it. And instead, he went the opposite direction. He said, this is more than likely going to be the end of me. And what I don't want to do is spend the rest of my life throwing up. Yeah. And feeling like crap. So I won't. And I, again, it's still a little emotional for me. It probably always will be, but I totally respected that decision, just to be clear-eyed about what he wanted to go through.
And it's one of those things too, where we adhere to our core identity in the face of these struggles. It's not necessarily going out and making a bucket list. If you weren't one to jump out of an airplane, right, a cancer diagnosis may not be the thing that makes you go do it. It's just who you are at the end of the day. We hone in more on that.
I think so. I think certainly interviewing the doctors themselves, like asking them, one of the questions I would ask all the hospice doctors and nurses when I would have like private moments with them is, why do you do this? The doctor's, job is to sort of quote, fight death, end quote. And they were like, it's not. Doctor's job is to make life livable. Mm-hmm. And this is life. It just might be the end of life, but it's in some ways a privilege to help people write that last chapter. And it was a really interesting way to look at it. And I've always really admired that bravery and that ability to sort of look at it as a privilege. I also think, you said something about like people want to be who they are straight through to the end. That gets to like legacy as well. And I think people forget that there's more to life than just living a little bit more. Mm-hmm. There are people who will pull out of therapy because they don't want to bankrupt themselves, because they will have worked their entire lives to save just a little bit of money to give on to their families, and they don't want it to evaporate. They'd rather hand a college education to their child than another month of school. And so I think when we narrowly look at the choices that people have in fighting, quote, air quotes, right? Like treating, going against whatever you want to say, like tactical retreat, to use the war metaphor, is certainly possible. Yeah. More than once, people pulled off therapy to the surprise of their doctors when I was following them. And they said, I'm going to pull out of your study, not because I don't want to be part of the study, but because I'm not going to be doing any more treatment. And my answer was always, can we talk about that? Like, my study's not how do people stay on therapy? It's how do people die, you know?
I mean, it makes me want to go back to the war metaphors a bit and then double down on my dislike of them, because I think of a story, somebody in the New York Times, he was a Wall Street financial investor. He's 61 years old. This story came out like a month ago from when we're recording this in July. And he was told that you have this lung cancer, it's traveled to your brain, and you'd be lucky to live 12 months.
Jeez.
So the quote, literally, Brad, investing in his future. This guy is rich. You know, he has all this money. And his quote at the very end of the piece was like, I'm just going to sit down and have a glass of wine. And that's how I'm going to spend my day. Not going to, you know, he's doing a little bit of travel, but as you would if you had that much money, but it's nothing out of control. It's nothing, I shouldn't say out of control, nothing outside of himself.
It didn't seem to provoke an extreme.
Right. I have all this money saved up for this future that I expected to live. I'm going to blow it all now. No.
Go back to Dabda, right? When you start doing things like spending all your money, that's denial.
Right.
Right. Like,
and what makes me go back to this story about Clemens and the story you're telling, it's like the decision to say, I'm going to stop therapy, I'm going to finish treatment, is also a reflection of self. And when we use metaphors, war metaphors like fighter and champion, then we have to look on the flip side.
Well, you frame it as surrender then.
Right. That's what I'm seeing it as, and it's another problem that's bubbling within me when we start talking about war metaphors.
And I think people reject that idea, right? So many oncologists view the fight against cancer as the like true doctrine. Like that's the hardest fight there is. Doctors are here to fight. Fighting cancer means fighting death. Therefore, being a doctor means fighting cancer. And I'll always ask them like, but you ask it in different ways, but it always comes down to like, but you lose virtually more than half of your fights, let's say, right? It depends on what era we're talking. When I was doing it, a lot more people died a lot more quickly. We've done a really good job quintupling survival in lung cancer and stuff, but still a lot of these fights that these doctors talk, if they view living as winning, then they lose. And they don't view living as winning. They view length of living as winning. My job is to give people as much time as possible, as much good time as possible. Now, not all patients want as much time as possible, no matter the cost. Yeah. And that's the gap. And so it really comes down to cost benefit analysis. It comes down to what is our job? And I think, takeaways from this are, I don't know if everybody needs to be feeling like a fighter. We've assumed that that's what keeps people going. But for me, the war metaphor is far less motivating than the strength metaphor, that people don't need to know what you're carrying, or even if they do, you can still carry it and still be of use to others.
Right. And I feel like we could still take these stories of people going through this harrowing testing events and say, we're celebrating humanity. We're saying this is the strongest of us as people, without glorifying them in a sense of, putting that additional pressure. You don't have to fight to save the universe. You have a legitimate problem and you are seeing your way through it. And as other human beings, that's impressive.
Yes. And when you reduce it down to your job now is to fight for your life, that's very disorienting for people who are embedded in a social structure. I don't want to just fight for me. I want to be helping members of my community, my church, my family, whatever it is, right? I mean, you don't have to be like this upstanding, whatever, like, I don't want to let down my fellow Hells Angels. I don't really care what community you're in, right? You are an embedded figure within that context gives us meaning. And to strip it away and go, now all I want to do is fight for myself, that becomes very disorienting for people. We've touched on so many subjects, right? But like lung cancer being different from non-melanoma skin cancer, right? Like there's goodies and baddies. And oncologists will tell you that, not as a patient, but when you're studying oncologists, they'll tell you there's good cancers and bad cancers. There's good conversations and bad conversations. Triple negative breast cancer is a bad conversation because you have to say there's nothing for you, but you don't say that. You say what we have is the old stuff kind of thing. Anyway, there's so much to talk about. Cancer is fascinating, the emperor of all maladies, as they say. But it's gratifying to work in. It's very much a privilege to talk to people who are facing their own mortality. I will say that. So I always appreciate people taking time to think about it. And I just want to recognize some of the people, not going to mention them, but, in my head, I'm going through a Rolodex of people that I've talked to who were clearly short on time on this earth, who made time to talk to me. That time was valuable.
And to me, that feels like the extent of like human bravery facing what is the end. Yeah.
Yeah, some 28-year-old researcher who isn't even married with children yet, asking you, like, tell me about your journey and taking the time to do so with dignity and respect. Those were the people that I carry with me now.
So thanks, Brad.
Absolutely. That's it. Yeah, for Breaking the Code, I'm Brad Davidson.
And I'm Gabriel Allen Cummings. Thanks for listening, everyone.
Okay, bye-bye.
Breaking the Code is a podcast created and produced by Havas Health and Use Medical Anthropology Department. Hosted by Brad Davidson and Sneeka Garcia. Content and post-production audio editing done by Gabriel Allen Cummings. And inspiration from all of you. Thank you for listening and for your continued support. If you enjoy these episodes, we would love to hear from you. Please leave a rating, subscribe, and send us a message to our mailbox at medicalanthropology@havas.com. Until next time.